Hello, my name is Jessie Gold, and today I'd like to share my presentation on post-traumatic stress disorder in adults. So I'm going to start out by talking about the diagnostic criteria. So for criteria A, for diagnosis of PTSD in adults, that would be the actual exposure to a traumatic event. So actual or threatened death, serious injury, sexual violence, and it must be experienced in at least one of these ways: direct experience, witnessing the trauma, learning about the traumatic events if they occurred to a loved one, if the event was violent or accidental. The other criteria is experiencing repeated or extreme exposure to the details of traumatic events. So in the DSM-5, they include first responders, police officers, and I think we could add people living in countries under occupation, people living in countries undergoing genocide, war, things of that nature. Here I have a chart of the types of trauma and their rate of like how often they express themselves. This study was done in Australia, and it was a internet survey of 244 adults. So it might not be it might not be the best for talking about things in the United States, but at least we have a little bit of an idea. Noticing that physical assault, sexual trauma, and sexual assault rape are the highest occurring causes of post-traumatic stress disorder in adults, men and women. And then we have sudden death of a loved one, transportation, accidents, etc. down the line. And I do believe that if this study was conducted in the United States, we would have a category for military combat. So criteria B is experience of one of the following symptoms that it has to be associated with the traumatic event and begin after the traumatic event occurred. So here we have recurrent, intrusive, distressing memories. And then we have dreams or nightmares related to the traumatic event. There's also dissociative reactions like flashbacks, where a person feels as if they're still in that moment. And there's also prolonged psychological distress when exposed to either internal or external triggers that symbolize or represent or remind a person of the traumatic event. The criteria C, these are dealing with avoidant characteristics associated with the traumatic event, either one or both of these, and that would be avoidance or efforts to avoid distressing memories, thoughts, or feelings, and also avoidance of external reminders. So avoiding people, places, activities, situations that would arouse distressing memories that are associated with the traumatic event. Criteria D, this would be, this is related to the mood associated with the traumatic event, worsening after the event occurred. And then for this criteria, you would need two or more of the following. So one would be inability to remember an important aspect of the traumatic event, like dissociative amnesia or, like dissociative amnesia and not due to head injury, alcohol, or drugs. We also have persistent and exaggerated negative beliefs. So, like constantly blaming yourself for the trauma, believing that no one can be trusted anymore after this horrible thing happened, seeing the world as dangerous, seeing yourself as more vulnerable in a dangerous world, um, and the anxiety that's associated with that. There's also persistent distorted cognitions about the cause or consequences of the traumatic event that lead the individual to blame him or herself or others that are not associated. So self-blame can happen a lot in these situations. Like, if I had only done this, if I had only done that. Here we have persistent negative emotional state. So the constant feeling of horror, anger, guilt, shame, fear, and then markedly diminished interest or participation in significant activities. There's also feelings of detachment or estrangement from other people, and an inability to experience positive emotions like happiness, satisfaction, love. And you might notice here in this criteria D, there's a lot of overlap with some symptoms of major depressive disorder. Criteria E, this is associated with the hyperarousal in mood and behavior after the traumatic event. And for this criteria, you need 2 or more of these symptoms. We have irritable behavior, angry outbursts, verbal, physical aggression towards people and objects, and reckless or self-destructive behavior, hypervigilance, exaggerated startle response, problem with concentration, and sleep disturbances. For criteria F, it's just referring to all of the previous criteria, and criteria A, B, C, D, E, and making sure that it's lasting more than 1 month. So it needs to last a month or longer for it to be considered the diagnosis for the diagnosis of post-traumatic stress disorder to be considered. Criteria G, this would be how it actually affects your life. So the disturbance causing significant distress, social impairment, occupational difficulties, difficulty functioning, difficulty in relationships. Is this adversely affecting your functioning and your life? Criteria H is just making sure that these symptoms aren't attributable to medication, alcohol, or another medical condition. And there is one subtype to post-traumatic stress disorder, which is dissociative. And to be post-traumatic stress disorder with dissociative symptoms, you do either experience depersonalization, which is the feeling of being detached, outside your body, outside, like you're an outside observer of your mental processes, your body, feeling unreal, time moving slowly. And there's also derealization, which is similar in that it's persistent experiences of unreality surrounding the world around the individuals. So feeling unreal, dreamlike, distant, distorted. And once again, one must rule out that this is not attributable to the physiological effects of the substance or another medical condition. So the risk factors for PTSD. there are three main areas of risk factors. Pre-traumatic factors, so your childhood, your life leading up to the traumatic event. Peri-traumatic factors, what's going on during the event itself. And post-traumatic, how are you soothing yourself? Do you have a support system, etc.? That can all affect whether you're going to just be someone who has experienced a trauma or a person who has post-traumatic stress disorder because of that trauma. So those are the risk factors. So pre-traumatic risk factors are divided into temperamental, environmental, genetic, and physiological. So childhood emotional problems, like anxiety or prior childhood traumatic exposure, and also the existence of a mental illness, the already existence of a mental illness such as panic, depressive disorder, OCD. And temperamental, I think, would also include adverse childhood experiences, such as poverty, separation of parents, abuse, being raised by an addict, etc. The second is environmental. And here we go with being from a lower economic status, lower education, childhood family dysfunction, parental separation or death, family psychiatric history. And I put a link at the end of this PowerPoint about adverse childhood experiences and how they can affect your affect a diagnosis of post-traumatic stress disorder as well as other health disorders. It's very interesting. So then we have our genetic and physiological pre-traumatic risks, and that includes a greater risk for females over males, a greater risk if you are younger at the time of the trauma, and certain genotypes that might have increased risk. So peri-traumatic, while the trauma while the trauma is happening, and here the severity of the trauma greatly influences the likelihood of PTSD. The greater the trauma, the more likely an individual is to develop PTSD. Post-traumatic risk, that would include temperamental and environmental. And the temperamental would be if an individual has negative appraisals about what happened, if they lack coping mechanisms, if they lack community or social support, they develop, there's a greater risk of developing post-traumatic stress disorder. Environmentally, a risk for a post-traumatic risk would be exposure to repeated upsetting reminders, and also the experience of subsequent adverse life experiences. So background and prevalence. So according to the DSM-5, there is a lifetime risk for PTSD. PTSD lasting 12 months or longer in U.S. adults is 3.5%. So a good chunk of the population. There are lower estimates in Europe, Asian, African, and Latin American countries. And in these countries, the prevalence of post-traumatic stress disorder is more around 0.5 to 1%. Rates are higher in veterans and those who witness trauma for their occupation. And the highest rates of post-traumatic stress disorder are found in survivors of rape, so both male and female survivors of rape, military combat, captivity, and ethnically or politically motivated internment or genocide. So here we're talking about countries under occupation, countries under dictatorship, countries undergoing ethnic cleansing. There are higher rates of post-traumatic stress disorder because there's higher rates of trauma existing. So compared to non-Latin Caucasians, there are higher rates of PTSD among Latin Americans living in the United States, African Americans, and Native Americans. There are lower rates of PTSD in Asian Americans. More about the background. So the PTSD is considered a stressor disorder, but it involves complex interactions affecting relationships, and also the understanding of PTSD has involved studies in biology. So neuropsychology, cognitive psychology, social psychology. There's a lot of studies out at the moment about the HPA axis, the sorry, I'm losing words. But basically the adrenals, the pituitary gland, and the hypothalamus, and how they relate, and how your hormones are communicating with each other, and noticing disorder in the HPA axis in post-traumatic stress disorder patients. Individuals with PTSD are 80% more likely than those without PTSD to have symptoms that meet diagnostic criteria for at least one other mental disorder. So there's a lot of comorbidity associated with PTSD. They're 80% more likely than those without PTSD to have depression, bipolar, anxiety, or substance abuse. PTSD was officially categorized as a mental disorder in the 1980 edition of the DSM. Methods of diagnosing the disorder. So one way is dimensional assessment, which is cross-cutting of symptoms, differentiating with overlapping systems. There's a lot of scales that are used for assessment processing, including self-report measures. And you want to establish the duration, the intensity, the frequency, and the presenting symptomology. And here we have several different assessment tools that are listed in our textbook, including the Folston Mini Mental State Examination, Cognitive Somatic Anxiety Questionnaire, and the Beck Depression Inventory. And if we continue on, there's also the Generalized Contentment Scale, the Penn Inventory for Post-Traumatic Stress Disorder, which is also a self-report measurement. Most of them are self-report measurements. And the Los Angeles Symptom Checklist, which lists 17 symptoms embedded in a scale measuring general distress. So those are some ways to diagnose. Another thing to consider is differential diagnosis. PTSD shares symptoms with adjustment disorders, other trauma disorders, acute stress disorder, anxiety, obsessive compulsive, major depressive disorder, personality disorder, dissociative, conversion disorder, psychotic disorders, and also traumatic brain injury. There's a lot of overlap between post-traumatic stress disorder symptoms and traumatic brain injury symptoms. So let's talk about some cultural considerations. ethnic groups, identity, religion, and spirituality can help establish cultural behaviors that are different from behaviors in the dominant culture. And it's important to recognize that there are different behaviors, different ways of perceiving experiences within different cultures before you put out the diagnosis of post-traumatic stress disorder. And in recent literature, it's indicated that historical trauma suffered by minority and marginalized populations are important considerations. A lot of times, minority and marginalized populations deal with the reliving experiences of their ancestors, such as colonialism, slavery, natural disasters, and war. And that's really important when dealing with a patient. Are they coming from an ethnic or cultural background with a history of genocide, colonialism, slavery, and how is that affecting their perception of their own trauma, etc. And yeah, there's an assessment tool called the Cultural Formulation Interview that allows a clear evaluation of how the individual approaches and responds to their problems. And this takes into account cultural influences. So that can be an assessment tool that has in mind cultural factors. There's also looking in the DSM-5 appendix, where there are lists of the best studied culturally related idioms of distress across cultures. For example, in Latino cultures, you might hear the phrase ataque de nerviosa, which can relate to panic, anxiety, and possibly post-traumatic stress disorder. But it has them listed out here in the appendix for multiple cultures, so that the practitioner can get a better understanding of where their patient is coming from based on their culture and what idioms they are using. And also, PTSD is more prevalent in females than males across the lifespan. So more cultural factors. This is all based on a study done by Muldoon and Lowe based on social groups and how that can affect the diagnosis of post-traumatic stress disorder. So members of particular social groups are intrinsically related to the likelihood of experiencing a traumatic event. Those in poverty, minorities, etc. Also, certain social groups will have a higher likelihood of witnessing traumatic events. So here again, we have, depending on what your socioeconomic status is, depending on what group you belong to, what your ethnicity is, what neighborhood you're from, where you grew up, your social group, in that way, you can have a higher likelihood of witnessing traumatic events. Also, political, military, and social identities can at times buffer the impact of traumatic stress because a support system is in place already based on the social group. The relationship between group level factors and available social support can protect against post-traumatic stress. That's kind of repeating the same thing I just said. Shared social anxiety can provide social support, lowering pre-traumatic and post-traumatic risk. So depending on whether you're part of a ethnic group or sexual orientation or any kind of group where you are experiencing more peer support, that's going to affect whether you're receive a diagnosis of post-traumatic stress disorder or not. Here we have more cultural considerations. Here I looked at a study by Hinton and Luis Fernandez from 2011, and it talks about how the trauma response varies so much based on time, place, social group. So it's really difficult to fit it into this standardized PTSD diagnostic criteria, and a lot of times it won't fit into that because of the complexities of the human condition and the complexities of human suffering. Also, although PTSD accurately describes some features of universal trauma response, Hinton and Luis Fernandez says that its clinical utility lags behind that of more local forms of trauma-related psychopathology, including cultural syndromes. So here, once again, we have cultural syndromes that perhaps are even better than post-traumatic stress disorder at describing what a person is going through in a particular cultural group. Post-traumatic stress disorder risks pathologizing human suffering, like reducing social and moral implications of traumatic events like war or genocide into this biological set of consequences, without looking into the causes and consequences of human suffering and the socio-political background, which might be more important to look into than like who got PTSD and who didn't. So a question that they pose is, does PTSD, as currently defined, apply equally well across cultures? Is it found with equivalent frequency? And the answer in other studies is no, that I've read. Or instead, do cultural factors pattern alternate presentations of PTSD? So that would be like cultural syndromes. And once again, a little bit more about cultural considerations from an article about the implications of the cross-cultural study. So a cross-cultural analysis of post-traumatic stress disorder symptoms yielded these results. There were lower rates of avoidance and numbing symptoms in some cultures. The impact of meaning attributed to the trauma differed across cultures. Whether some would consider it a spiritual occurrence, that the dreams were meaningful, etc. Like the nightmares were meaningful, etc. So there are also a variation in exposure to particular types of trauma among certain groups, which we've talked about quite a bit already, but we're talking about genocide, torture, etc. And the effect of the type of trauma and the socio-cultural context on the expression of individual symptoms, it can differ based on the socio-political context, like genocide, etc. Living under occupation. I mean, yeah. Though living under a dictatorship. The role of cultural symptoms in linking PTSD to particular comorbidities is something to look into. So once again, we have this idea of cultural syndromes. And what was also noticed was that there's a higher rate of somatic system in certain cultural groups. and that physical, cognitive, and spiritual effects are examples of negative expectations that may follow a traumatic event. And then, depending on the culture, there's a different salience of each of negative expectations. So, yeah. Let's move on to treatment modalities. So based on one study, I found that three treatment modalities seemed to be most effective, and that was exposure therapy, cognitive behavioral therapy, and EMDR. Exposure therapy is where a therapist helps patients confront their traumatic memories, and this can be done through written or verbal narrative, detail recounting to your therapist. This can also be include repeated exposure to trauma-related situations that are being avoided, and illustrate that they are now safe. And an example would be driving a car where a road traffic accident occurred. Cognitive therapy or cognitive behavioral therapy, it focuses on identifying cognitive distortions that came about because of the post-traumatic stress disorder, and some that leads to an individual to overestimate the current threat. It also focuses on changing your beliefs and how to interpret behavior, including guilt and shame. So it's all about noticing cognitive patterns of belief and behavior, and from there, coming up with coping mechanisms, or not even coping mechanisms, but different cognitions, different ways to think about things. EMDR is the use of bilateral stimulation, which can be eye movements, it can be taps, it can be tones, it can be little buzzing eggs that you hold in each hand, in the left and the right hand. And as long as it is bilateral stimulation, meaning you're experiencing something from both sides of your body. And it's hypothesized to stimulate a patient's information and processing to help integrate the event as an adaptive and contextualized memory. What I've noticed in EMDR, and I haven't studied it, but is that it leads to a lot of insight. And it's through that insight that one is able to kind of move through trauma, move through these unpleasant emotions, these memories, these fears, and somehow the bilateral stimulation can create this kind of like awakening to insight that I wasn't able to get to without that. So that's my personal experience with EMDR. But there's plenty of studies out there if you're interested in reading more about EMDR. So when we're talking about secondary prevention of PTSD in adults, it's basically, measures to minimize a person being diagnosed with PTSD again. And that would be to optimize social support, minimize external stressors, work on their perception of threat to lower it, and doing a cognitive behavioral therapy within the first month after the trauma occurs for people that have elevated risks. So, treatment modalities. This is based off of a study that I read. So these came out in the study as like the most effective methods of treating post-traumatic stress disorder. So we have safety and tolerability exposure therapy, which we've talked about a little bit. Virtual reality exposure-based therapy, which is replaying the traumatic experience with VR goggles in a safe space with a therapist. And it can help someone feel relive those experiences, relive the memory while feeling safe. There's internet-based cognitive behavioral therapy, plenty of websites where you go through a cognitive behavioral therapy process, and that seems to be effective. In-person cognitive behavioral therapy is probably equally effective. So we have eye movement desensitization and reprocessing. That would be the EMDR that I just talked about. Psychodynamic psychotherapy, interpersonal psychotherapy, yoga, and that's based on a study by Rhodes, Spinalosa, and Kolk. Mindfulness-based therapy, hypnotherapy, body-based therapies, so somatic therapies, dance and movement therapy, and associated with that underneath we have physical therapy. And then we have pharmacotherapy. So the leading pharmaceuticals used to treat PTSD would be SSRIs. So your fluoxetine, your Zoloft, your Trintellix, I don't even know if Trintellix is, all of your SSRIs. Secondarily, benzodiazepines, which don't really show that much effectiveness. There's also other kinds of antidepressants, trazodone, mirtazapine. They have also not shown the best results. In general, pharmaceuticals work best for PTSD treatment when in conjunction with therapy, with another therapy like talk therapy. We've also got some other kind of cutting edge treatments, repetitive transcranial magnetic stimulation, that is using kind of like a helmet with magnetic pulses sent into the brain, and it's a very it's like a month-long process, and it's shown in studies, it's shown to be highly effective for some people. And then we have electroconvulsive therapy, which works for some people, but for some people the risks outweigh the benefit. So here is just another image from that psychoeducational website. I did not include MDMA-assisted therapy in any of my lists because I don't think it is approved yet, but that is something that could be a treatment in the future. And here I have kind of a trauma expert, Bessel van der Kolk, talking about the therapist's role in treating post-traumatic stress disorder, as well as the efficacy of EMDR. And I'm just going to play a couple minutes of it.
It's important to think about the nature of trauma. And trauma is not some unpleasant thing that happens to people. Unpleasant things happen all the time. And we're actually quite well equipped to deal with unpleasant things. Trauma is something horrendous, something that makes you stare with horror. Trauma is about horror, something that you stare in the face and it's too much. You cannot possibly imagine what you can do. You think your life is over. An experience like that is an experience you don't want to remember. And so the core of trauma is this need to put it away and to try not to remember it. Trauma is about making it safe for people to remember, making it safe for people to stare reality in the face. I think traumatic post-traumatic stress reactions is about being unable to face the truth. And so at the end, exposure treatment is important, but not lasting people in the memory of the trauma. Confronting with it, because that is traumatizing, put it again. Now, we need to make it safe for people to observe what happened back then without them becoming freaked out and overwhelmed by remembering. So our job as clinicians is to make it safe for people to remember what happened back then, and for them to come to the conclusion, yes, it's happened to me, it was terrible, but it happened a long time ago. And that's the core skill of becoming a trauma therapist, is the capacity to help people to safely remember. The first modality that taught me that it's possible to help people to feel safe was EMDR. And for me, EMDR is an indispensable modality of treatment. If I could not do EMDR, I don't think I could be a good trauma therapist anymore. It may not be universally true. I believe if you're a very good body-oriented therapist, as Peter Levine or Pat Ogden or some other people teach, you can probably process trauma as well through those modalities as you've been doing for EMDR. I also suspect that if you're a very good hypnosis expert, you will be able to help people come to a very safe place where they can actually observe what happened. But for me, EMDR has always been a very important part.
So thank you for viewing my presentation. Here are my sources. There's a lot of great studies in here. Really interesting stuff to read. I recommend in your free time. I'm laughing because we all have so much reading to do. Looking into some of this stuff, especially if you are interested in becoming a trauma therapist. In my last slide here, I have some additional supplemental viewing that for the first one is about treatment modalities, and it's Bessel van der Kolk again, and he's talking about overcoming trauma with yoga. I found it really interesting. He just talks about the process of how yoga can help reduce the symptoms of PTSD. And the other video I have is by a doctor named Nadine Burke-Harris, and it's about how childhood trauma affects health across a lifetime, not just mental health, but physical health. And that is a really fascinating TED Talk that I recommend looking into. So thank you so much for
Trauma is about heartbreaking, gut-wrenching feelings. It's not about...
Thank you so much for watching my presentation, and I look forward to hearing your feedback.